Diarrhea. Now, what you see behind me on the board is most of the causes of diarrhea already out in the categories. It's going to follow the order of the chapter from our book. Now, the first thing in all diarrhea is to exclude infections, because without excluding an infection, you can't know, basically without excluding an infection, you can't go on to these other things like celiac and Whipple's, because infectious diarrhea is simply hundreds of times more common than something like carcinoid syndrome. Infectious diarrhea is thousands of times more common than a very, very rare disorder like Whipple's disease and tropical sprue. We have some joint findings, we have some eye findings, we have some CNS findings, we have some joint findings, some eye findings, and some CNS findings. These things are infinitesimally small compared to infectious diarrhea. So the first thing to do with all forms of diarrhea is to say, well, let's see, as an example, 26-year-old he has lunch at 4 p.m. And at 5:30 p.m. she has a big bloody diarrheal poopy. She has a big bloody diarrheal poopy and abdominal pain and a fever and abdominal pain and a fever and big bloody diarrhea. She had lunch at 4. She has diarrhea at 5:30 with blood in it. What's the etiology? And the answer is the most likely thing is Campylobacter. Now, Campylobacter is the most common of the infectious diarrheas. So just statistically speaking, I didn't tell you chickens and eggs with salmonella. I didn't tell you they ate infected meat like Shigella. I didn't tell you chickens and eggs. We talk about it with salmonella. We're saying simply statistically what is the most common cause of infectious diarrhea and food poisoning. And the words infectious diarrhea and food poisoning essentially can be used interchangeably for infectious diarrhea and food poisoning. The chief resident walks into my office yesterday, says, Conrad, can you help me for a second? Dude's orthostatic, hypokalemic, 9 bowel movements in 2 hours, and it's food poisoning, infectious diarrhea. What's the difference? Now, what if she said that she had eaten eats Chinese food at 4 o'clock, and at 5:30 she has a big, bloody, diarrheal poopy. She ate Chinese food. An hour and a half later, there's a big bloody diarrhea. The most likely organism in that case is not Bacillus cereus. Not Bacillus cereus, because no matter how many Chinese you eat, you can't get blood from Bacillus cereus. No matter how much staph toxin you get, you can't get blood from staph toxin. When I put these up here and I say you have food at 2 o'clock and diarrhea an hour later, food at midnight and diarrhea an hour later, the most common wrong answer is always saying Staphylococcus. Because when you're a first and second year medical student, you get taught based on time frame. But that's not the way the questions go in your exam for Step 2, Complex 2. Questions there say, what's the most likely diagnosis? What is the best initial test? What is the most accurate test? What is the best initial therapy? So when you have the word blood, in the history, it cannot be Bacillus cereus and Staph aureus, because they give no blood. They present with vomiting, but not blood. No matter how many times it says, I had a gay man on a camping trip out with 5 other gay men on a camping trip, it cannot be giardiasis. It cannot be giardia, because no matter how many unfiltered water you have in eating bear poop in the woods, giardia does not give blood. Viruses do not give blood. Giardia does not give blood. Staph aureus does not give blood. Bacillus cereus does not give blood. Not give blood. Not give blood. So when you're looking at an infectious diarrhea question, and you have to answer the first question, which is, what's the most likely diagnosis? The answer to that question is based first on blood, no blood. That's first. All the things they taught you in medical school about saying risk factors, chickens and eggs with salmonella, and shellfish with Vibrio, shellfish with Vibrio parahemolyticus, shellfish with Vibrio parahemolyticus, shellfish with Vibrio vulnificus is true, but it's not as important as saying all of these. Campylobacter can give blood. Salmonella, Shigella, Yersinia can give blood. You look for Yersinia because it likes to grow in cold steel, cold and iron. Grows in blood transfusions. Yersinia likes to eat iron. But blood. Now what happens? What's the best initial test if your question does not clearly describe blood? The best initial test, if your question does not clearly describe blood, is fecal leukocytes. The best initial test to tell these apart is fecal leukocytes. Giardia does not give blood, doesn't give leukocytes. Staph does not give blood, does not give leukocytes. Bacillus cereus does not give blood, does not give leukocytes. Viral does not give blood, does not give leukocytes. Methylene blue is negative, methylene blue is negative, methylene blue is negative. But all of these, Salmonella can give blood, it can give white cells. Campylobacter can give blood, can give white cells. Shigella, Yersinia, Vibrio parahemolyticus, Vibrio vulnificus, these can all give blood and white cells, blood and white cells, blood and white cells. Ultimately, the only way to tell them apart Ultimately, the only way to really be able to tell them apart is by stool culture. Ultimately, the only way to be able to tell which of these organisms it is by stool culture. Now, if the question says the person has hemolytic uremic syndrome is going to be associated with hemolytic uremic syndrome E. coli 0157H7. For hemolytic uremic syndrome. Giardia, what is the most accurate test? Did you know that a stool ELISA antigen is better than 3 stool ova and parasite exams? A stool ELISA antigen better than 3 stool ova and parasite exams. And giardiasis was treated with metronidazole 25 years ago, 30 years ago, and giardiasis is treated with metronidazole now. There is no therapy for viral diarrhea. There is no therapy for Bacillus cereus. Write it out. There is no therapy for Staph aureus. Write it out. Most common adverse effect of metronidazole? Most common? Disulfiram reactions with alcohol and bad taste in your mouth. Now, we can put Clostridium difficile associated diarrhea with the other infectious diarrheas. Clostridium difficile associated diarrhea, antibiotic associated diarrhea. Antibiotic associated diarrhea can go with all these, except let's give the little exception. The exception is Clostridium difficile is diagnosed with a stool toxin because it's very difficult to diagnose. It's very difficile to diagnose, and that's why we have to use a toxin. Because Clostridium difficile doesn't grow in regular culture medium. That's why it was called Clostridium difficile, Clostridium difficult, not es fácil, es difícil. Because it didn't grow in regular culture, we had to find it with a toxin. Now, the good news is that there's not that much news for you for Clostridium difficile. The best initial therapy was metronidazole 30 years ago. The best initial therapy is now metronidazole. If it gets better and it recurs and gets better and it recurs and it gets better and it recurs and it gets better and it recurs, the first recurrence gets retreated with metronidazole. So Clostridium difficile, otherwise known as antibiotic diarrhea. Best initial therapy, metronidazole. It gets better and comes back, metronidazole again. What if it fails metronidazole? If it fails metronidazole, then vancomycin. If it fails metronidazole. What do you do if it fails vancomycin? And what if it fails vancomycin? Fidaxomycin. What if it fails vancomycin? Fidaxomycin. Fidaxomycin is the answer to the question, which of these do you give when you continue to have recurrent episodes? What do you give for recurrences? Fidaxomycin. So let's look at the other forms of diarrhea here. What's the difference? Well, lactose intolerance is very easy because half of you out there have it. You say, stop the milk and see if you get better. Give them a glass of milk and see if they get worse. Well, which form of milk product could you have if you had lactose intolerance? Come on, which one? You could still use yogurt. Yogurt's okay. Yogurt is okay because the bacteria have already eaten your yogurt. The bacteria have already partially eaten the yogurt. What you're eating is really the digestive content of the organisms that have already pre-digested your milk sugar. So yogurt has already been pre-eaten. Ugh, disgusting. And stop the milk. Now, if they really asked you what is the most accurate test, the most accurate test is an increase in the osmolality of the stool because you're looking for unabsorbed particles. You're looking for unabsorbed lactose, and that's looking for osmolar particles of lactose in your stool. What's different about carcinoid? Carcinoid is episodic. Carcinoid, it comes and goes. Carcinoid, there's episodes of flushing, wheezing, diarrhea, flushing, wheezing, hypotension. Carcinoid, there's episodes of flushing, wheezing, hypotension with your diarrhea. So what's the clue to the question, which of the following is the most likely diagnosis? It says it goes on off and on and off and on and off and on with episodes of hypotension. Carcinoid. The best initial test is a urinary 5-hydroxy-indole acetic acid. A urinary 5-HIAA. Urinary 5-hydroxy, urinary 5-hydroxy-indole acetic acid is the metabolite of the serotonin in carcinoid syndrome. Episodic. You look for what's different, What else is different about carcinoid? What else is different and unique about carcinoid, different from the other things? What is different and unique? What is different and unique? What gives me the answers that I seek? Different and unique. And the answer is cardiac problems. The difference is that you get tricuspid insufficiency, right-sided lesion, and pulmonic stenosis, right-sided lesion, right-sided lesion, right-sided lesion. Tricuspid insufficiency and pulmonic stenosis. What is different? Well, you're bathing the right side of the heart with neurotransmitters. Now, almost by definition, 95 to 97% of carcinoid syndrome is from metastatic disease. It's already metastatic through your liver. You've already used up all of the oxidative and metabolic capacity of the liver because you're already metastasized. It's not carcinoma. It's like a carcinoma. It's carcinoid. Oh, it's kind of like, oh, are you human? No, I'm like a human. I'm humanoid. Are you a man? No, I am a machine in the image of a man. Android, humanoid, carcinoid. Do you use cholesterol? No, I use something like cholesterol, steroid. So when you have something that's like carcinoma, you don't get symptoms until it's already metastatic. So therefore, it's very hard to surgically correct carcinoid syndrome. Carcinoid syndrome will only be curable if it's the small number that's bronchial. If it's the tiny number of bronchial, you can do surgery and remove them and the person is fixed. But 95% is GI carcinoids that are metastatic to the liver. Episodic wheezing, flushing, diarrhea, tips. And if they are episodic metastatic disease, then we treat it with octreotide because octreotide is a synthetic somatostatin. And that synthetic somatostatin slows down the bowels. Now, the truth is, nothing I've said here about carcinoid has changed in 30 years. Nothing I've said about lactose intolerance has changed in 30 years. Irritable bowel syndrome, what is different about irritable bowel from the others? There's pain. And sometimes you have diarrhea. There's pain. And sometimes there's constipation. There's pain. Abdominal pain. And you have diarrhea alternated with constipation. There's pain in irritable bowel, and it's less at night. There's pain with diarrhea. There's pain with constipation. There's pain with diarrhea alternated with constipation. There's pain that's less at night. Irritable bowel is a pain syndrome. It is a pain syndrome that also sometimes has diarrhea and constipation. There is no test. You exclude other things, but there's no specific test to prove you have irritable bowel syndrome. Irritable bowel is a bowel that's contracting too often. Irritable bowel is a bowel that your bowels are contracting more frequently. It's muscular spasm, excess muscular contractility of the bowel. Your bowels and my bowels have a rhythm to them, a natural rhythm to them. 3 times a minute in the stomach, 12 times a minute in the duodenum, 6 times a minute in the ileum. But an irritable bowel, it goes too fast. It's like tachycardia of your butt. It's tachypoopia. And first part about irritable bowel syndrome is to give fiber. Bulk it up, stretch up your ass. So instead of the bowels contracting like this, now it's got all this fiber in it. Instead of now it contracts like this. And it slows down that bowel, stretches it out. Now there are other antispasmodics, dicyclomine and hyoscyamine. They relax your bowel. They're like Ativan for your bowel. They're like marijuana for your ass. What's happening? I used to get to contractile. Now I take it easy. Wasting away again in jejunumville. Oh, searching for my ileocecal valve. So you're relaxing your bowels because these drugs are antispasmodic. Relájate, cálmate su culo. And make it go slower. Now, ultimately with irritable bowel, because it's a pain syndrome in people who are depressed. Irritable bowel, it's a pain syndrome in people who are depressed. We can use tricyclic antidepressants because it's a pain syndrome. Tricyclics work for neuropathic pain for peripheral neuropathy. Tricyclics work for neuropathic pain for peripheral neuropathy. Tricyclics work as antidepressants. Tricyclic calms down your bowels. Tricyclic antidepressants. Tricyclics calm it down. Pain syndrome, stretch up your butt with fiber, dicyclomine, hyoscyamine, tricyclic antidepressants, slow down your bowel, make it better. Okay, so now we're here in the big malabsorptions. The big malabsorptions, whether it's celiac disease, also known as gluten-sensitive enteropathy, chronic pancreatitis, which is basically a dead pancreas, Whipple's disease, which is basically an infection of your bowel. You treat that with antibiotics, ceftriaxone, other antibiotics. All of these forms of chronic malabsorption are going to cause stool that to be fat malabsorption. And you have oily, greasy, floating, flying, frothy, foul-smelling, fermented, rotting stool, fermented, rotty, oily, greasy, floating, flying stool. Rotting in your butt, it's like a stool-flavored yogurt fermenting in your ass. Celiac disease, chronic pancreatitis, Whipple's disease. All of them will be positive for Sudan black. That's the stool stain for fat. All of them will be positive for Sudan black. They don't all have eye and joint and skin findings of Whipple's disease, and that's the easiest one. We use PCR for the Tropharema repellii, biopsy for the Tropharema repellii, and we give antibiotics for the Tropharema repellii, and that's Whipple's disease. Look for eye and joint findings, and CNS abnormalities. How are you going to tell the difference celiac disease and chronic pancreatitis? Well, which of these gives you bleeding? Celiac disease, chronic pancreatitis, or both? They both give oily, greasy, floating, flying stool. They both give weight loss because every time you have fat malabsorption, you have weight loss. Every time you have fat malabsorption, you have weight loss, oily, greasy, floating, flying stool. They both give you bleeding. They both. Whipple's too. Because they make you malabsorb vitamin A. Chronic pancreatitis, my pancreas is dead. Celiac disease, my whole small bowel has been lost. Antibodies against my small bowel have denuded my small bowel. So I can't absorb vitamin D and K. So I both have a low calcium because I malabsorb vitamin A, vitamin D, vitamin K. They both give visual problems. They both cause malabsorption of vitamin A, vitamin D, vitamin A, vitamin D, E, K. They both give oily, greasy, floating, flying stool, fat in your stool, Sudan black, weight loss, oily, greasy, fermented, floaty, flying, foul. As if there's anybody's stool who smells good. Taking a stool smell history. How does your stool smell? Oh, my stool smells foul. It's nasty. How does yours smell? Oh, mine smells like flowers. No, Chateau Neuf de Crap, 2018. So, vitamin A, vitamin D, vitamin E, vitamin K, they both cause bleeding, both cause low calcium, both cause bone because they don't have calcium. Both give weight loss, both have Sudan black, both, oily, greasy, floating, flying, both. What about B12? B12 malabsorption, celiac disease, gluten-sensitive enteropathy, chronic pancreatitis, which means dead pancreas. Chronic pancreatitis most often, by the way, has normal amylase and lipase. Most often has normal amylase and lipase because it's burnt out the pancreas. Chronic pancreatitis with the CT scan that's about 80 to 90% sensitive. Chronic pancreatitis in which the secretin stimulation test is most accurate. I give IV secretin and I look for the stimulation. I give you IV secretin, there's nothing to stimulate, it's dead. Remember, amylase and lipase would be normal in the same way that you won't find any hair in my bathtub drain. And you go, oh, Conrad Fisher, he's got really healthy hair. Why? Because we went to his bathroom and the bathroom drain did not have hair. But look at you other people. You go, oh, look at, he's got all this hair in his bathroom drain. She's got all that hair in the bathtub drain. She must have very unhealthy hair. Conrad's got healthy because there's no hair in his bathtub drain. Well, if you don't have anything to lose, you won't find anything here in the amylase and the lipase. CT scan is 80 to 90% sensitive. Most accurate test is secretin stimulation testing. Which of them gives B12 malabsorption? Celiac disease or chronic pancreatitis? And the answer is, we said both give fat and stool, both give weight loss, both give oily, greasy, floating, flying stool, both give a positive Sudan black, both cause bleeding because of malabsorption of vitamin K, both give low calcium because of malabsorption of vitamin D, both give visual disturbance because of malabsorption of vitamin A, and with B12 it is both. Both give B12 malabsorption. Both give B12 malabsorption because you need an intact bowel wall to absorb B12. So if your small bowel wall is destroyed, you can't absorb B12. The other point, chronic pancreatitis. Did you know that you need pancreatic enzymes to absorb B12? Most people don't know that. You need pancreatic enzymes to absorb B12. B12 goes into the mouth and the R protein from the saliva attaches to it. You need that R protein so that the B12 can survive the fires of your stomach. Once the B12 gets out of the stomach, pancreatic enzymes detach it from the R protein so it can attach to intrinsic factor and be absorbed in the ileum. Again, you need the R protein in your saliva to absorb B12. The B12 comes onto R protein in your saliva so it can survive the acid of the saliva, and then inside the duodenum, the pancreatic enzymes detach the R protein so it can attach to the intrinsic factor, and then it's absorbed later on in the terminal ileum. Oh, so they both cause B12 malabsorption. Both. Finally, iron. Which of these causes iron malabsorption? Celiac disease, gluten-sensitive enteropathy, or chronic pancreatitis? And the answer is only the celiac disease. Only the celiac disease, because we don't need pancreatic enzymes to absorb iron. You only need an intact duodenum to absorb iron. So celiac disease frequently presents as a person who has iron deficiency anemia too. It's common because it damages the duodenum. Now, chronic pancreatitis is easy to treat because you just replace the enzymes. You can go get pancreatic enzyme replacements anytime. You can get over the counter. You can go to any food nutrition center and get pancreatic amylase, lipase, trypsin, and chymotrypsin over the counter in a pill, because it's not considered a medication. It's considered a dietary supplement. And as a dietary supplement, pancreatic enzymes do not require a prescription. That's a biggie. Next one is that chronic pancreatitis is basically permanent, dead pancreas. Celiac disease, you could say it's easy because it's gluten-sensitive enteropathy. Let's knock the wheat out. Stop having wheat. The hard part in celiac disease is to get the diagnostic tests, which is anti-gliadin antibody. Anti-gliadin is a $5 word for wheat. You're looking for antibodies against wheat with celiac disease. Part of the antibody grabs the wheat antigen, part of the antibody grabs your bowel wall. So it's like anti-wheat antigen and grabs your bowel wall, and your bowel wall is the endomysium. So you get anti-endomysial antibodies because that's the bowel wall. Next, anti-tissue transglutaminase. Anti-tissue transglutaminase, long word, is another way of diagnosing celiac disease. Anti-tissue transglutaminase. And the ultimate answer to the question, what is the most accurate test for celiac disease, you will get right. The most accurate test for celiac disease ultimately is a small bowel biopsy. It's a small bowel biopsy. It's ultimately the answer for celiac disease. And here's the question. You know that you can replace pancreatic enzymes. CT scan is 80 to 90% sensitive. Secretin stimulation is the most accurate. IV secretin, look for release in the pancreas of enzymes. IV secretin, look for release of pancreatic enzymes. And celiac disease, gluten-free. I see gluten-free all over the place. I don't even think people know why they're getting it. Why are you in the bus shopping in the gluten-free section? Well, I don't know. Do you have celiac disease? What's celiac disease? Well, I notice you're buying things that are gluten-free. Yeah, gluten must be bad for you. Buying gluten-free. So let's say okay, not okay. If you have celiac disease, vodka, is vodka okay or not okay? Vodka is not okay. That's why people are wrong about it. Vodka is not okay because vodka is made from wheat. Now everybody's paying attention. Okay? Now, next, beer. Okay, not okay? Beer? Not okay, because beer is a wheat derivative. Beer is a wheat derivative, and gluten-free beer tastes basically like fermented urine. Next, wine. Okay, not okay? Wine? Okay, because wine, we have recently discovered, is made from grapes. Okay, rice. Okay, not okay in gluten-sensitive enteropathy. Bueno, no bueno. Achaya Buddha. Janiman. And the answer is rice is okay because it's not a gluten derivative. It's not a wheat derivative. In celiac disease, no wheat, rye, oats, or barley. No wheat, rye, oats, or barley. Barley. Now, next one. Whiskey, not okay. Whiskeys are wheat derivatives. Where people fail is they fail at the level of dietary compliance because we live in a very wheaty society. And it's very hard to go through life, particularly if you're a vegetarian, and not be having some form of wheat. And they fail at the level of the alcohols too, because most people don't know vodka is a wheat derivative. Oh, look at all this. This looks like diarrhea and malabsorption, doesn't it? The first thing to do in diarrhea is to exclude infection. No matter when they tell you when you ate or what you ate, always go to blood first. Campylobacter statistically is the most common. Vibrio vulnificus and Vibrio parahemolyticus come with shellfish. Yersinia likes to grow in iron, cold and iron. Ultimately, the only way to tell these apart is with a stool culture. Oh, the last part I want to mention on this is if you do have bad infectious diarrhea, what's the best antibiotic for bad infectious diarrhea? Is a quinolone. For bad infectious diarrhea is a quinolone. There is no treatment for viral diarrhea. There is no treatment for staph and bacillus cereus. Giardiasis is metronidazole and tinidazole. Next, irritable bowel syndrome is a pain disorder. Pain with diarrhea, pain with constipation, pain that's less at night, but it's a pain disorder. The only tests are tests to exclude things. Put in some fiber and bulk up your guts, stretch your bowels, yoga class for your intestines. Dicyclomine and hyoscyamine. You're going to have to look stuff up. One of the occupational hazards of being with me is it looks like I'm so exciting you'll remember on one time, but it's not true. You got to go look it up or it fades away. They're antispasmodic. Tricyclics work because this is for neuropathic pain. Tricyclics work because they're anticholinergic. They slow down the bowel. Tricyclics work because tricyclic antidepressants are good in people who often have a history of depression. When you have the malabsorptions, the fat malabsorptions, they all cause weight loss. They all cause floating, flying, oily, greasy, flying stool, Sudan black. They all cause the malabsorption of vitamins A, D, E, and K. But they both cause malabsorption of B12 because you need an intact bowel wall and pancreatic enzymes to absorb B12. But you don't need pancreatic enzymes to absorb iron. Whew, big section.